Nobody's going to be successful without passion. Just to throw up an organization called an ACO and not change attitudes and the way we care for people probably isn't going to accomplish very much. Remember that the real heart and soul of the Affordable Care Act is something called patient-centered care. How many of us have had the experience of been admitted to a hospital or seeing a physician and feeling like they talked over your head or around you or used terms and so forth you didn't fully understand? They weren't really focused on you. They were focused on what they needed to do. Busy days, lots of people to see, move along, hit the ground running and keep going until nighttime. They got a lot of stuff going in their lives. And historically, there's a lot of surveys that show that people called patients don't feel that they're really focused on. And so this changing to a patient-centered care model, the ACO and its kind of cousin, patient-centered medical homes, those are entities that are cropping up because, if run properly, they will enhance the delivery of patient-centered care. I'm very passionate about patient safety. Served 10 years on the National Patient Safety Foundation board and studied a lot and learned a lot. And we can do a lot more in safety. But I think if we focus more on the patient experience and the family advocate and so forth, we'll enhance outcomes and improve quality. Remember this about quality. You can never have quality in the healthcare system if it's not fully safe. It can be fully safe and still not be quality. But it can never be quality if parts of it are inherently unsafe. So the triple aim of ACOs is to reduce costs, that's important, but the other two are maybe more important. Improve the health for a general population of a community and improve the health care for individuals within that community. The NCQA, whom I'm sure many of you are familiar with, they're a national accrediting body, will accredit ACOs, and some of the ACOs have sought accreditation. And I wanted to share with you, I think this is in the discussion guide, isn't it? You may be able to look down and read it along with me. They have a very simple, straightforward definition for what an ACO is. It's an alliance of physicians, hospitals, and other providers that coordinates care for a particular group of patients to improve quality and reduce costs. Pretty simple statement. Hard to do, but a pretty simple statement. Here's a map that somebody put together of Medicare ACOs. Now, what we're going to learn this afternoon is there are multiple types of ACOs, and they're not all for the benefit of Medicare. But you can look on the map there very quickly and find South Dakota. Not much action in South Dakota on Medicare ACOs. There's only 2 or 3 states with can't be less action than you guys, tied with you, Alabama being one, and North Dakota's not got much going either. But look over there in your neighboring state of Montana and Wyoming, or down to the south, or to the east. You're surrounded by heavy activity of ACO development. Now this is just Medicare ACOs, and let me look at my notes here. There are 253 right now Medicare ACOs. These are ones who qualified under the Medicare Shared Savings Program and contracted with CMS. However, there's a total of 488 ACOs in the whole country. Now this is the map that shows all ACOs. It includes the Medicare ACOs and everyone else. Once again, not much happening in South Dakota. Not much happening down in the deep south. But there's action in all the rest of the country, heavy action. Now, maybe it's not right to have ACOs in South Dakota, but you'll have to convince me why it can't work, why it's working other places and it couldn't work here. Maybe it just hasn't been tried yet. Maybe there's too much confusion.
Well, let's talk about that for a moment, actually, because I have a little bit of a breakdown on the numbers of ACOs in rural America. Now, you'll find that 65% of the ACOs that are currently in existence here that are shown up on this map are exclusively metropolitan area ACOs. And that's a much easier case to make for lots of reasons. But if you look at 32%, you'll see that 32% of these ACOs are a mix of metropolitan clients that they serve, and they also serve rural areas. So metropolitan and rural mix. 4% of them are exclusively rural ACOs. So that's nine of the ACOs are absolutely exclusively rural. And if you look at rural areas overall, you'll see that there are Medicare beneficiaries in 343 rural counties in 38 states that are assigned to 88 Medicare ACOs. And then overall, approximately 30 million Americans are currently being served by some form of an ACO, whether that's a Medicare Shared Savings Program ACO or some kind of hybrid of an MSSP and a private payer ACO. Carson, do you want to tell us a little bit about the other different types of ACOs that are out there?
Yeah, on your outline, we use the term flavors of ACOs, like it's Ben and Jerry's or something. There's basically 7 different flavors. Some of them are like a renal ACO. I don't want to spend any time talking about it because it's very unique, and if you're not in the renal dialysis business, it wouldn't even apply to you. But there are 3 that I would like to touch on. What's called MSSP, which stands for Medicare Shared Savings Program. This is the one you've probably heard the most about. This is one where you have to take risk, but you can get rewards. And the rewards are tied to improving quality and reducing costs. There's what is called one-sided risk or two-sided risk. A lot of people are starting out with one-sided risk. That means there's no downside, there's only upside. You enter into a 3-year contract with CMS, and the first 2 years you can elect to have no downside risk. There are no penalties if you don't improve quality or reduce cost. However, by the 3rd year, they want you to take both sides of the equation. Some people are going ahead and saying, we know we can do this. We have the infrastructure in place, we've got the information technology, we've got the training, we've got the leadership, we can do it from the get-go. So they're taking both-sided risks. You may say, well, wow, that seems kind of stupid. They get more on the upside if they take both-sided risks than they would get if they only take the upside risk. So there's flavors of that within MSSPs. Now, in addition to MSSPs, one of the things about a Medicare Shared Savings Program, ACO, that is a challenge for a lot of rural providers. You have to have at least 5,000 Medicare beneficiaries in your ACO. They'll be assigned to you based upon their prior experience with their personal physicians and who's involved in the ACO. But in some places, if you look at the very narrow market that you're in, you might be tough to find 5,000 Medicare beneficiaries, right? So you may have to expand your geographic reach and your vision of what your market could be. And we'll show you some examples of that in a moment.
And to develop some partnerships with other types of providers that may get you to the 5,000. You know, the 5,000 is, it is a challenge, but I don't think it shouldn't be an insurmountable challenge.
And a lot of people in other states, for example, in Billings, Montana, they've dealt with this beautifully and created a wide-ranging ACO with thousands and thousands of beneficiaries. The next one is called the advanced payment model. And this has been popular in rural America because it provides you with money up front, i.e. advanced payment, to get up and running. The government recognized that particularly in rural America, there's a lack of electronic medical records, other types of information technology and data gathering. So they said, okay, fine, we're going to help you out. We'll give you an 18-month interest-free loan of X amount of dollars for you to hire staff and to implement new information technology. So the money's out there. Now they're going to want to be paid back over some period of time, but it's interest-free money. How often do you get interest-free money from anybody? So I would encourage you, if you're in a very rural area, to sit down, put a team of advisors together and begin to say, how can we get in this game? And you may come to the conclusion it's not the right game for you, and I will respect that. But what I can't respect is not even considering it and investigating it. The third is the leader of the pack. That's the private payer ACO. They don't get as much notoriety in the press because they're doing this on their own. And we'll talk about some of the challenges and issues of partnering with a private payer and creating an ACO like that in a few minutes. But these are the 3 main flavors: MSSP, advanced payment, and private payer. Carrie, you want to pick up on that?
Yeah, to tag on for a moment about the private payers, you know, Carson said they're doing this on their own. There's some significant benefits to that, right? You know, they don't have to have the 5,000 beneficiaries participating. You know, they're not operating in the constraints of the 400 and some page, whatever it is, MSSP rule. So they're able to act a little more creatively in partnership with some of the providers to set up some really interesting and really innovative and unique models. You know, they can set their own benchmarks. They're not, you know, they're not looking to CMS to set their benchmarks for them. And I even saw a study recently of private ACOs that have been in existence since 2009. And those ACOs have showed significant cost savings without sacrificing the care. Now, one of the downsides is that some of these commercial payers, they may not really favor these, all upside arrangements, right? With CMS, with the MSSP model, you can take the one-sided model, right, where you're not paying a penalty basically if you don't meet your benchmark. Commercial payers may not be quite as amenable to that. They want generally their providers to share a little bit of the risk with them. But again, you've got a lot of flexibility to work out an arrangement and to hammer something out that works for everyone.